So the session's being recorded now, and we're looking at some personal hygiene. What I need to do, because I'm going to start by asking you a question. And the question is, how important to you are the fundamental skills for patient care? So I'm going to release this as a poll. And get you to have a think and have a go. So we're nearly there. Just give it a few more seconds, and then share. I've just pressed the wrong button to share. I was trying to share it, but I will. I'm going to close the poll, and I'm going to now share. So hopefully you can see that. And so 84% of you thought it was equal to the academic knowledge, and 21% thought it was more important. And thank you very much. Nobody said it was less important than academic knowledge. And the majority of you went for it's equal, and I would say it is, and agree with you. But some of you thought it's more important than academic knowledge, and I don't dispute that some of you may actually feel that being skilled at giving fundamental care is really important. But you do need some underpinning knowledge to enable you to give better care, and that's where we're going off. So I'm going to close that one and move on and ask you the next question, and ask you what you think about this term. Are you too posh to wash? Some of you may have heard this term, and some of you may haven't not. And the thing is with this is over a number of years, and there's some references at the end to a document about students considering themselves too posh to wash. And what, as you all probably know, that the student nurse training is under a big review at the moment, but certainly over the past 5 years, and probably back just a little bit further, there's been a lot debated in the nursing press and also the national press about nurses being too posh to wash these days, and that we don't train or encourage students to understand the fundamentals of personal hygiene, and that because you're doing a degree course, you're far too posh to give personal care. And you will find a lot of people will have a lot of opinions on that. I'm just going to look to see if anybody's actually, none of you have actually said anything yet, so that will be interesting. So some of you may have a think about what you think about that, but we're going to move on and think about why personal hygiene is important. Now, many of you will have been or will shortly during your course be looking at Maslow's hierarchy of needs, and it's like a triangle. And it's also about how people feel safe and feel comfortable. And we start at the bottom, the fundamental part of the triangle, about physical survival, water, food, warmth, exercise, etc. And actually, and safety and security are the two cornerstones of this triangle, and they're also two cornerstones of personal hygiene. As we move on, these things are still very much important when we're thinking about fundamental patient care and fundamental skills around personal hygiene, but essentially Maslow's hierarchy of needs fit in very nicely to what we consider in meeting our patients' needs. We think about personal hygiene, so we'll move on and have a look at some of that. My colleague who originally put this together was quite keen for us to think about Florence Nightingale and actually how interesting that statement is. And we'll explore the reason why. So, what do we mean by personal hygiene? Here we go. There's quite a few items on there, and there's a little bit more that comes with it. There's a thing about people's skin and their comfort. There's things about how their mouth is and their teeth, and we'll explore why that's important. People's hair, nails, eyes, ears, nose, all those outer aspects of the body, but also things that may be associated with, and we'll explore those a little bit further. So what is the purpose of personal hygiene? But also, why is it important to assess that patient and the benefits? And we looked at Florence Nightingale, thinking there that the benefits is the antithesis of being slowly poisoned. As I said, an interesting thing. Somebody's asked if there's a too posh to wash poll. Interesting question there. I'll deal with that when I stop for some questions in a second. Purpose of personal hygiene. There's an awful lot of things here. We've looked at Maslow already, so here's your well-being. We always think probably at first about comfort. Any of you who've been unwell and in bed, don't feel like doing anything. Some of you may decide that you don't actually want to have a wash or a shower or anything for a day or two. Some of you might actually be in hospital and had personal experience of being in a bed, and hospitals are usually hot places, and sometimes in the hospital, people in hospitals have infections with high temperatures which make things worse. So there's a thing around about comfort. Now, we have a mixture of ladies and gentlemen in our audience, and I think this is fairly applicable to all of us, whether you're a lady or gentleman. I mean, the men amongst you may feel that ladies spend more time fiddling around with their hair or hairstyling. I'm not going to judge any of you, but there's this thing about comfort and well-being being linked here, and self-esteem. Think about this. If you're not fresh after your wash and your freshen, and your hair is not tidy and needs washing, some of you will actually feel less of a happier, well-being type person, and it's about self-esteem. When people are unwell and say, I don't want to bother, part of it's to do with the effort it might take, but also actually 99.9% of the people that we care for who cannot manage to provide personal hygiene for themselves will feel better after we've assisted them and raise their self-esteem. We'll talk about shaving in a minute, but men especially, having a shave adds to that sort of fresh feeling for the day. The cultural and religious beliefs and norms we need to think about, and there are certain cultures and religious beliefs about personal hygiene and about the way it should be conducted. And for example, people who are Muslims will like to cleanse themselves under running water, which provides a challenge for us as nurses if they're bedbound and bedridden, but it's not impossible to do, and you need to think about that. That's just one example. The security and the well-being and self-esteem and feeling better fits in again as with Maslow, but then there's the social norms. Some of you may meet people who are considerably old, who actually normally would only bath once a week. In this modern day, people feel that you should be washing and cleansing first thing in the morning when you get up, and have a bath nearly every day or a shower every day, but you may actually meet people who would normally not bother, and therefore if you're trying to persuade them, you've got to think about what is normal for them, and what would be best. People who are unwell generally don't feel as cheery as they may normally will, and also there's those psychological factors about feeling not clean, not healthy feeling, looking unkempt, and actually improving those kind of things. And there are many others, but there's others about how people perceive them. how their relatives or visitors may perceive them, how we might. There's quite a lot of psychological, social norms as going on, as well as things that might be cultural, quite a lot of factors to think about. One of the key things that nurses do, and nurses do well, and you're beginning to start to develop your skills, is about assessment. And assessment, there are lots of different assessments that we do, but if we think about assessment in terms of personal hygiene, I've already talked about social norms and what their normal routine is. Most people will have a bath or a wash first thing in the morning, but actually it might not be their normal routine. They might prefer to be later on. Certainly people with long-term conditions may take quite some time to get going in the morning, and they might actually feel better after they've had morning medications and may feel they want personal hygiene attended to later in the day. Again, the beliefs and about what they feel and their religion or any of the cultural things I've just mentioned. And the other thing about assessing is what they prefer. Do people want to have soap, water? Do they use some particular cleansing agents? For example, many women these days use wet makeup wipes for cleansing. We use wet wipes a lot in hospital environments because it's easy, because you throw them away as you're using them, but people may use flannel, sponges, a whole range of things, and how they would prefer and what they would use, and you need to identify that. The other key thing around is their limitations and abilities, and it's important to consider the self-esteem and the mobility aspects, and certainly the worksheets that you have will ask you to explore that further. So, if people would prefer to wash their faces themselves, and they can do, then actually let them do that. Again, if they prefer to wash and clean the perineal area, and they can do, then again for their embarrassment and their dignity, then that's fine. What you may find is a history, tradition, and sometimes you may come across nurses, but you certainly come across people who may have been in hospital many, many years ago, where the nurses do everything. But actually, we moved away from that. We encourage independence and dignity, as well as it might be part of a rehabilitation program that they start to provide care for themselves, to encourage limb movement, dexterity, and ultimately rehabilitation. So you've got to identify those limitations and identify where you can help them. Maybe parts of their personal hygiene they can do themselves, and maybe parts that you would need to assist them with because they can't. And that usually in turns is areas that are difficult to reach, but we boil right down to things like teeth cleaning and all that kind of stuff as well, and we'll move on a bit further. So this is evidence-based, so potential benefits: it can reduce anxiety and promote relaxation. Interesting about timing and structuring the day, and I've just talked about some people might prefer to have a later wash than others, but when, you know, some things days need to be structured. People who don't have structure to the day is not very common. Most people like to have a structure in terms of their day. One of the big things is about skin integrity. Washing stimulates skin and stimulates circulation, and also the moving around whilst you're washing will relieve pressure points. It gives you the opportunity to assess the patient further, assess them in terms of their ability to wash, but also assess them and get to know them a little bit more, chat to them about themselves, about their illness, about how they're feeling about it, what happens at home, and that, as well as looking at their skin integrity and their general skin tone, and all those kind of things all take place when you're giving personal care. You're engaging with the patient, you're communicating with them, you're starting off your therapeutic relationship with them. All of these can be done during this period of washing. I've talked about the circulation, the nurse-patient interaction, the communication, and also there's this interesting point about demonstrating care through physical contact. It's an interesting point because you also have to consider how people feel about you touching them, as it were, you know, giving them a wash or holding their hands, or giving them a reassuring, you know, hug on the shoulder or something. It's always difficult to gauge, and you will have been talking about these things within skills, and also you'll revisit it, but you're also talking about the sort of initial communication. And you do have to gauge and pitch yourself, and if you're somebody who is a very touchy person, you may have explored this already, you have to just think yourself, is the person I'm engaging with going to be okay with me being that way? And also about their dignity, because you put people in vulnerable situations where you're actually touching their skin and giving them personal hygiene. So there's all those kind of things. It gives nurses satisfaction. That's an interesting point for you to look at. Why does literature say that? People like to stand back and look and think about their patients and think about the contribution they've made to that patient's comfort, and seeing them in a nice tidy bed, all nicely spruced up and brightened up, is often something that nurses feel quite proud about and feel good that they've done something for the patients. Please do look at that further and have a little look and see what, you know, think about yourselves and think about, would that apply to me? Would that make me feel that I am actually providing a good service here and improving how I feel about personal hygiene? Right, stopping at that point to have a look at the things that you're saying. I'm sorry if people are having problems with the sound. I have got everything up on full volume. Somebody's sometimes connections. I am so sorry about that. Has anybody got any questions they want to ask about what I've said so far? No. Okay, I'm going to move on. Oh, so hang on, we've got some stuff coming in. Somebody's asked if I agree or care is often missed. Yes, and I'm going to go on to that in a minute, because actually, think about yourselves. Think about how you feel if you don't clean your teeth. Think about then how you might feel if you haven't cleaned your teeth for several days. Not that any of you would probably want to put yourself through that. How uncomfortable and sore is that? Would it put you off eating? It probably would. Not only that, if you're compromised and you're unwell, for example, again I'll go back to the fact of infection. If you, for example, if you've got a cold or something like that, then your mouth breathe. Or some people with long-term respiratory conditions breathe through their mouth. That dries out the mucosa, it makes it very sore and uncomfortable. Not only is it sore and uncomfortable, it hurts to drink, it hurts to eat. So actually you're doing people a major disservice to give oral care. So I'm going to move on. Problems with poor assessment and poor provision. I talked about the patient becoming independent. I've talked about pressure sores, checking pressure points. Personal hygiene, there is some link towards increased infection rate, again because of not cleansing the body. Any sort of skin infections can develop, and certainly the pressure sores can go into ulceration and become septic. It's antisocial odours emanating from the patient. Well, again, people might have infestations like nicks or lice, and if you don't assess it and realise what's going on there and it doesn't get treated, patient distress about feeling uncomfortable, and therefore they don't recover so well, and therefore they're discharged late, which increases the cost of caring for them. So once again, for you and for as we do, we will think about infection. There's your 5 moments of hand hygiene. Thinking about what you're doing with the linen is really important, and you need to ensure, and you'll be doing this in the ward, is making sure that you've got the linen skips handy. It's the right type of linen skip for what you need. Thinking about soiled linen, and there's just a little point about sharing washing equipment, wash bowls, flannels, and all those kind of things. Obviously, one patient, one set of stuff, that's it. Things get cleaned properly in between patients. And I wouldn't suggest that means flannels either. If you finish and you throw it away, if it's a patient's own flannel, then they take it away with them. So, before assisting a patient with personal hygiene, what do you think the issues are for the patients or the nurse? Does anybody, some of you want to have a think about what issues? I've talked about some of them, but I want you just to have a little think. I've stimulated you to think, I'm hoping. Okay, nobody's come up with anything. We'll go through them as we go. And there is often a little bit of a delay, but I'll pick them up. I've talked about the independence of the patient, keeping them independent in their dignity, consent. As always, you need to ensure patients understand what you're going to be doing and ask their permission to do so. We'd like to give you a wash. This is what we're going to do. Is it okay with you? Is it okay for me to clean your mouth? You have to ask those questions. You need to think about your risk assessment, so your manual handling and moving the patient around the bed, or the patient if they're in care home or anything like that, if they're people care in their home, then you need to think about manual handling and the aids that you require. You need to think about reducing infection. I've just talked about the linen. You need to think about, have they got pressure ulcers, and have they got is there a mobility assessment that needs to be taking place. Privacy and dignity, I've talked about it already, but ensure curtains are closed and doors closed on rooms to ensure, and also that if there are closed curtains, that people actually ask permission to come in before actually coming in and walking through. I recently assisted in a survey at one of the big hospitals in the southwest, where we were looking at patients' perceptions of how they've been treated, and I asked one lady, were you treated with dignity, for example, when you were washing the curtains around you? And she said the nurses were all very good. They made sure that once those curtains were closed, they stayed closed. If they went out to get changed the water and came back in, they asked if they could, can I come back in with this water? They never allowed the curtains to, fall open. I was very impressed, and obviously that was a good tick for that clinical area, but to me that's perfect. If that's the patient perception about how they're treated, that's the gold standard that we want to aim for. I've talked about preferences. Don't forget that stripping clothes and bedding off causes people to become cold, so you need to think about keeping them warm during the procedure, and also the water temperature. And usually you would need to change the water during the procedure because it will have cooled on the side. But what is warm and hot to you may not be to the person that you're assisting with the hygiene, so you need to obviously make sure it's not scalding you, but also check with them and say, I'm just going to put the flannel on you for a second there, is that okay with you? Thinking about how you position them, how you move them, and thinking about, keeping that nice and dry afterwards. Really difficult drying people because you don't feel it yourself. You need to ask people if they feel dry, and not to make them feel that you're hurrying them, and that you have got the time to ensure that their comfort is paramount. Right, has anybody said anything else? Yeah. Okay, somebody's raised about the embarrassment and somebody's talked about consent. So yeah, that's right. You know, you've got to think about being embarrassed. I guess you or I would be. So just think about that. If you put yourself in, how would I feel if this was happening to me? How would I like my dignity to be maintained? Then you're 10 parts there about providing that care for somebody that they will feel is good. So, issues for students. Skin condition. So, the condition of the skin. Think about its colour, what it looks like. Does it look healthy? Texture of the skin. You know, does it feel warm? Does it feel mushy when you touch it? Does it look like it's healthy? And comment on it if it isn't. Think about how the skin is smelling. Does it smell unusually unpleasant, or is there a reason for that, or is this something new? Thinking about the temperature of them, if they're very hot. Think about how papery or frail that skin may be to touch, because you need, it's part of your pressure risk to do those assessments. But again, obviously, when you're washing, you can assess all of those things. Please be aware of intravenous infusions. You won't be very popular if you trip on it and pull it out, or even if somebody's got a drain. So if you're in a surgical ward, they may have drains, again, draining blood away from the operation site. So make sure you know where they are, but you place them in a place of safety when you move somebody around, and that you don't trip over them. Many have. Warning you that you need to take that into consideration. I've talked about the flannel or the disposable wipes. People, it's their choice. The thing is with flannels, once you've used them, then they're damp, and hanging them out to dry and all those kind of things come into it. Again, some people don't like soap because it irritates their skin, and some people use special creams. You need to find out. Don't forget the skin folds and the crevices in the elbows and the groin, around the neck. There's areas where dry skin can gather, and also that might still be damp. Pat rather than rubbing, so that you're not causing damage to the skin. And as I said, minimal exposure of the body. Just do one limb at a time, keeping everything covered and making sure people's privacy and dignity are maintained. I don't just completely expose the body. People will be embarrassed and possibly too frightened, not so frightened, but you won't want to say, could you cover me up please, although some people will. Really important. Let's look at nails. My colleague Kevin's put some lovely photographs on here of toenails. There's some issues here for people who have difficulty, manual dexterity as well as visually impaired for older, but also people with learning disabilities may not be able to work out how to do things in the best way, and obviously children may not. But you do need to be careful. People with diabetes who have poor circulation, that's peripheral neuropathy, because they won't have sensation in their fingers or toes, and won't necessarily know whether they've bashed or knocked something. You also need to be careful, and people raise this question when I do this talk, is about what's permissible within the clinical environment. Maybe just filing a little bit, but maybe a referral to a specialist podiatrist is required. You need to find out what the guidelines are about giving nail care. If they say that the nurses don't deal with nails, then you need to find out who does and who to refer them to, so that people's comfort. You've got an overgrown toenail here. This is needs to be dealt with by a podiatrist. This one has got some infection in there, and you see it's a bit red and swollen around that. So, and you things like athlete's foot as well. This is probably a fungal infection, which will need treating. So here, for example, as I said, make sure it's reported, make sure it's referred, because I mean, something like this has been on a long time, and it's probably impeded the way somebody has walked for a long time. This can be very painful, and again, putting on shoes, tight-fitting shoes and things, will be painful and also cause problems with walking, so quite important. Hair, we talked about hair earlier. Thinking, look at my hair when I came up on the webcam, thinking it looks a bit messy this morning. But there's that other thing, it's been given a low priority. But actually, if you're in bed again and it gets hot and sticky, it gets uncomfortable and itchy. And it is about promoting body image and choice and preference. Some areas you might go to will have hairdressers that will come regular and make sure that the patients identify, that you ask patients, would you like to have your hair washed? Family members may be able to assist. But the other thing is around this, you can always wash somebody's hair no matter how bedbound they actually are. It can be difficult, but it can be done. There are the products, the dry shampoo products that you can get, which aren't as nice as running water, but actually, can help make people feel fresh. And then the other bit is about beards and moustaches, about trimming those. Again, if people, people normally keep them fairly trim and they're getting, itchy or long or whatever, that's important to think about that. Shaving. Shaving's an interesting thing here, some people might prefer to use an electric razor, some people might prefer a wet shave. Using people's own equipment is okay. Generally, hospital razors are not the best. And the thing to say there again is about shaving and the chaps amongst you, the hottest water you possibly can will help. Follow the direction of the hair. Ladies, you're going to have to perfect some skills around shaving if you haven't. You might find a useful family member to assist, to allow you to shave them so you can practice. But you will need to do this. The other thing is with people who are older, because of sagging skin, it's quite useful to make sure their teeth are in beforehand because it will help shape the mouth area. And also, you will have to be gentle around where there are skin folds around the face, but it's worth doing. And again, I've seen it neglected, and actually, people, how important it is. For example, maybe about 5 years ago now, I spent some time in practice and I worked in a bay of 6 gentlemen, and one of the gentlemen I offered I said, would you like to have a shave? I didn't need to shave him, I just set up the equipment for him to shave, and he shaved himself. An hour or so later, he phoned his wife up on the telephone and said, gosh, the nurse this morning was the first person the whole week to offer me the opportunity to have a shave. I feel so much better. And I felt, one, pleased, remember the nurse satisfaction that I had made that difference, but also disappointed and unhappy that this thing that actually only took me 3 minutes to set up and he got on with it, anybody should have done that and should have noticed that he may well wanted, or any other gentleman would have wanted a shave. The other point is some women do also shave as well, again, past postmenopausal and older, or they may have areas to shave. I'll take you back to my student days, my second ward placement, where we had this lady who had been there for a few months, was transferred to a nursing home, and she had Parkinson's disease, and so her dexterity was very difficult, and she asked me to shave her before she went to the home because she was all dark in her clothes and she wanted to look, and I felt that so sad that we hadn't actually felt that we perhaps had noticed, offered it, embarrassed to offer the opportunity, or that she felt that she couldn't have asked beforehand. It's a little bit of food for thought for you there. So I'm going to come on to mouth care. So somebody mentioned it earlier, what sort of patients may need help with mouth care and why. I've kind of identified some of those for you. I'm going to talk about see what you've got, see what you've said already, and see what you think about that question. Somebody's asked about patients that are unconscious. Well, that's an interesting one about consent. If somebody's unconscious and or they're ventilated in intensive care, what do you do about their mouth care? Or what do you do about their personal care? You can't get consent from them, so you would go ahead and do what's in their best interest. People who've got visual impairment, people with dentures or loose teeth, again, learning disabilities, special needs and disabled people. Yeah, good answers in terms of mouth care. People who've had strokes, people who may have amputees. There's a whole range of people that may need help with mouth care. Let's see. Unconscious we've talked about. People who've got facial injuries, again, obviously you need to think about how they may have wiring to their jaw, which means you've got to give special care. People with strokes, CV, cerebral vascular events. People who are nil by mouth, maybe being starved for some reason or other in terms of their gut is having problems with digestion, so you may actually be starving, or they might be before an operation, or they may have poor dietary intake. People who've been artificially fed through veins, or some of you may have actually seen percutaneous endoscopic feeding, peg feeding. Again, they still have secretions coming into their mouth. People with immunosuppression, people who are immunosuppressed, often have mouth ulcers because, again, it's a common area of breakdown. People who haven't had surgery, who require assistance with mouth care. People receiving oxygen therapy. Oxygen therapy is very drying, so it's going to dry secretions in the mouth and make you feel uncomfortable, tongue feel furry. There are certain drugs that will cause a dry up of secretions. People now malnourishment, we're going to talk about nutrition a little later on. Again, somebody's already raised the issue with people with learning disability or mental health issues who forget whether they clean their teeth or not, etc. And the very young and the very old, and practically anybody who can't actually get toothbrush in their mouth themselves, or you give them the equipment to do it in the same way I gave the gentleman the equipment to shave himself. So, we look at FRIA in 2004 about oral assessment. There are a whole range of oral assessments, and you may find in your placement there is a specific policy on oral assessment. But what you're doing essentially with all of them is you're looking at the tongue to see that looks healthy, that it's not coated or furred. You're looking at teeth, seeing if there's any loose or infected teeth, obviously, but the sort of general state of cleanliness of the teeth. Somebody's mentioned dentures already. If people wear dentures to eat, then they should be having them in to eat, because it makes it difficult for them not to, unless it's too painful for them to wear them. And then some people have ill-fitting dentures, that's for sure. The other thing is, as well, again, is about it's about their dexterity and things like that. So dentures. So you're looking to see these things. Are they producing saliva? Is it dried up? Are they producing excessive saliva? Is it a problem for them? Is it difficult for them to swallow their saliva? The internal membrane, the mucous membranes inside the mouth, they're healthy. I talked about mouth ulcers a little while ago. Again, even dry sore lips is uncomfortable. We've talked about their mental status and whether they are cognizant of being able to give hygiene. Again, what are they eating? Is their mouth painful? Is there anything else? So that's FRIA's assessment. That actually covers the majority of things that I would consider important to look at. You could look at some of these other ones and the references are available. So this is FRIA's assessment. So as with a lot of things, you're going to note that we do a lot of scoring systems and decide whether they're at risk. And then it's what you do, plan of action, and then you evaluate and monitor. And that's standard for assessment tools. But that's going to be available for you to have a look at. So what do we need? Do we wear gloves and apron? Well, you're coming across patient body fluids. Toothbrushes are the best way to clean a mouth, and you can also clean the tongue with the toothbrush, or if you want one of those posh toothbrushes that have got a tongue cleaner on them and toothpaste. That is found, evidence is found to be the best form of giving mouth care. Some people will use dental floss. You can use antibacterial mouthwashes, and that's freely available in placement areas. You can use a foam sponging stick with mouthwash and gently rub inside the mouth if the toothbrush is too painful to use. Or we talked about people who have their mouths jawed, you may just be flushing mouthwash through the best you can and cleaning where you can. There is a big debate about lemon and glycerine swabs you will come across in practice. They went out of vogue about 5 years ago. They're back in vogue now. They do dry the inside of the mouth. And so the jury is out as whether they're useful. Research has found that pineapple juice, pineapple chunks will be mouth cleansing. Sucking ice is nice. If somebody's nil by mouth, sucking ice will be okay and can be absorbed as normal, even if they aren't able to swallow things. That can refresh the mouth. And you might find use of sodium bicarbonate, hydrogen peroxide, but again, this is out of vogue at the moment. So when you go into your placement, have a look and see what's available, what they recommend in that clinical area. Be a little challenge for you. Well, we've mentioned dentures before, and toothbrushing, again, toothpaste and denture cleaning is fine. And again, soaking overnight in things like Sterident are really useful. A lot of people will take their teeth out when they don't need them because it's more comfortable, and so you do need to be wary that in patients' lockers and in bed linen, or again, in people's homes when you're going in to give care in homes, they may, park their teeth not in a pot that looks obviously like a denture pot. You may find that they'll take them out because they're hurting, and the furthest they can reach is the side of the bed or under the pillow. So you always have to be careful in looking for things like that and making sure you don't miss them. So a little bit, I've talked about this, what else we can do. Again, it's all around using and honing those observation skills, looking at the patient's condition, looking at their skin, looking at them, looking at how moving around the bed area, does it cause them to become breathless, is it tiring for them? All those things are good assessment skills you need to look at. I've talked about the communication. You could have an opportunity to discuss an awful lot with people and find out much more about themselves, because it's kind of slightly distractional from what you're actually doing, but you can glean an awful lot of information from people about, oh, so tell me how things are at home for you while you're washing their back or something like that. It gives them that social interaction as well. You could have that opportunity if you've got to do some health promotion. You could start talking to them about that, whatever that might need to be. It's important to look at wounds and their skin condition, and we'll talk about hydration and nutritional status when we go on to the next presentations. The other thing is, again, you're evaluating their psychological state. You're seeing their mood, you're assessing those things that go with that. Their physical state and ability, again, I've talked about how well they can move, how well they can care for themselves. All of those things are actually part and parcel. So look at how much you can actually do when you're giving personal hygiene. Loads. I'm going to have a look and see if anybody's got any questions, what people are saying. Somebody's talked about consent. If a patient doesn't have next of kin or is unable to give consent, for example, if they have dementia, who gives consent? Well, you can still ask somebody, do you want to have a wash? You can, and if they don't seem to be understanding you, you could prepare the equipment and start off with things like washing their hands and seeing how they feel about it, and then seeing if you can proceed with the rest. If they're fighting you off or saying, pushing you away, then you have to withdraw. Now, we've had this question before. What do you do if people decline to have personal care 1 day, 2 days, 3 days? Are we neglecting them? Nurses may feel we are neglecting them, but you have to respect people's decision making. You wouldn't force or physically restrain somebody to give personal hygiene, but you may be able to cajole them just to have a little bit. Why don't you just wash your face and hands, see how you feel after that? if they're saying they feel better, would you like me to just do around the back of your neck or comb your hair for you? How about we go just a little bit further and maybe come back a little later in the day and say, well, we did that bit earlier. How about we do another bit? Especially if people have continence problems, it's very difficult. Yeah, how can mental patients give consent? It's really tricky. At times you will have to back off if it's very obvious they don't want it done. If they haven't got capacity, usually if people haven't got capacity, they often may recognise that you're giving them bowl water and soap and flannel or something, and see how you get on and build it up and build that relationship with them. It can be quite difficult. You may have to just back off and say, we can't do that today. I've never had somebody completely refuse to have personal care for more than a day. Because the next day when I've gone back, they've said, actually, yeah, all right, get on with it, even if they, I feel like I could do with it. Don't forget, it's an instilled routine and behaviour in our lives. But we can't force people, and if they don't want to have personal hygiene or assistance with hygiene, then you have to document it. You may decide after a few days that you need to think about what you're doing. But to restrain somebody to giving personal hygiene is something that I've never seen. But that doesn't mean to say that it hasn't happened. Usually you can persuade somebody, even if they haven't got capacity, as I say. But it's an interesting point to consider. Again, when you go into a placement area, and when you're going into placement and people are dealing with dementia all the time, it would be worth asking that question and say, what happens? Interesting point. I shall investigate myself as well, because as I said, I've never ever been able to not persuade somebody even to have what we call a limited wash to freshen up a little bit, because generally they feel better. If they're completely not cognizant of what's going on in their world, quite often you could just do it in hands and face, but obviously the people can be at risk of deterioration, especially, again, as I said, if we have a continence problem. Okay, whoops, sorry, I've just inadvertently whipped forward. So, in summary, fundamental role of the nurse, giving care and assisting care. It's an essential part of patients' care. Don't forget the patient's individual needs. I've talked about that quite a bit, and so you talked about those things as well. Their privacy and dignity, and also thinking about how you can assess them, what planning you can do, documenting the care you've given. If somebody has washed part of themselves and you've had to help them with the rest, it's important to document that so nurses that come after or therapists that can see what needs to be done to plan how to rehabilitate somebody. The other thing is, obviously, you've got to consider your infection control and think about that evidence-based care. So there's a few things that I've raised, some in the evidence. Again, there's some references there for you to move things forward. And it's about this time now, as first years, it's important to ask people questions about why you're doing things or why they're doing things they do, without feeling like I'm asking questions they probably think I'm stupid. It's really important because it helps you frame you in nursing and not blindly going along saying, oh, we'll do that because that's what it is. Why are you using this particular cream? Why are you using this particular mouth care? Why this, that, and the other? Anything that's a policy or procedure or guideline that the organisation where you're doing your placement, they will have documents to support that and references, so you can look behind it. And as I say, things come into fashion and things go out of fashion. And for me, it's like, why should we stop using these? What has the research said to stop using this? Or why we reintroduced it? And you will find that as you go through your career that things will change, and sometimes you go back to things that you've done before, which makes it all interesting and keeps us on our toes. So we come to that point at the end. It is now 10 to 12. I suggest we start the next session at 10 past 12, 20 minutes, grab a drink. Some of you might want to eat something at this point. So I'm going to start the next one. There's more references there. Say it's on the web, on the Moodle page already. And then we're going to talk about nutrition, which is timely after we've had a drink and something to eat. So I shall be leaving this. I'm not going to stop the broadcast. I'm going to stop the recording. So why is good nutrition important? So some of this links in with your biology that you'll be doing, and some of it links into some of the other modules that you'll be doing as well around health promotion and things like that. And some of you may know these things anyway, and I'm just reminding you of them. Thinking about energy, growth, repair, resistance to infection, and body functions, brain function. What you may have looked at before in biology or in a previous life is you're looking at these things, but not necessarily looking at them with ill health, but some of you may have done. So, just to remind us all, the food groups, and oops, sorry, I didn't mean to be that quick. So recap your information. We're going to go back in. Okay, so thinking about our carbs and our energy and our vitamins and our meats and our meat substitutes and our milk and dairy products, and all these things are readily available to all of us, including fatty sugary foods, which we'll look at, and our carbohydrates, fats and vitamins. And as always, everybody needs a little bit of something in order to function. You may well have seen this Eat Well plate, which is looking at what is a balanced diet. So this is the thing we look at the moment. Large area of fruit and vegetables, large areas of carbs, and then we've got our small areas. Some of you may eat differently to that, depending on what health kick you're on at the moment, depending on what fad diet you might be taking, and all that kind of stuff that goes with it. So we have, in 2005, a health action plan. You will see the re-emergence of a large range of health promotion and the roles of healthcare professionals in health promotion and dietary promotion. Something you and I are going to talk about is about the nurse's role in healthy eating lifestyles, and how we can promote good nutrition as part of our role and why that is important. Now this is in 2005, this piece of work was done, and so the recommendations about your fruit and vegetables, 5 portions a day. Now recently I've personally read that they're saying that 5 portions a day isn't enough. However, conversely, I've looked at research that said, or commentary on research about where did the 5 a day come from, and actually is that right kind of thing, and we see a lot of stuff around these kind of things on television, you know, especially BBC One. They seem to be on a bit of a mission to explore fads and phases. And I read recently this thing, where did 5 a day come from, and they said it was all created in America, where they wanted to make sure that they were selling enough of their fruit and veg crops to keep the farmers sustained, i.e. in California, where we're talking about oranges and orange juice and orange growing. But that's just one of those interesting aside kind of things. Increasing fibre, there's a big thing, as we know, since this came out, around salt, and about salt being a hidden killer, about how it raises blood pressure. Again, the issues around saturated fat, all the dangerous fat and the not so dangerous fat. And here again we're seeing a return to natural animal fats, where things like butter and lard are actually better for you than some of these modified fats. So as I said, these things do go around and around. And again, reducing added sugar intake is interesting here, and since 2005 we're now looking at about added sugar into our meals, our ready meals, again hidden sugars, and there's this call for restaurants and supermarkets to declare on packaging in supermarkets and restaurant menus how many calories, how much sugar and all that kind of thing is available in it. So it's really interesting. how things have moved since 2005 and grown a bit more in the nation's consciousness. And we'll look at that as well. So we have looked at health eating guides, but it does change when people are ill. When people are old, their energy requirements decrease with age because their basal metabolic rate changes, and obviously their physical exercise is reduced. And so therefore foods with concentrated protein and minerals and vitamins are more important, as well as the vitamin C and vitamin D, and spending out time for vitamin D. And again, there's been stuff again in the last year or so about actually how sunbathing for the elderly improves their vitamin D, improves the nutrition, and actually improves their well-being as well. So there's this well-being of sitting in the sun and that sort of nice feeling it gets, but actually helps the vitamin D. And so how many of you saw lots of old people out sunbathing over the past few days? I didn't notice any more than normal. But interesting things. So, what are current issues around nutrition? Tell me what you think. I've sort of hinted at a few. Okay, you're right. Hospitals don't offer a balanced diet. Sugary cereals and breakfasts, lots of snacking, afternoon cake and sandwiches. Should we be offering more nutritious food in hospitals? And patients don't get anywhere near their 5 a day. I don't know what the rest of you think about that. I'd like to talk about that in a minute. High sugar intake is key. The increase in diabetes, absolutely. High obesity levels, again, sugar and snacking. High salt intakes, and people being aware of what they're actually eating. How many of you have been down the supermarket aisle and seen snacking bags of crisps, which are like double the size of an ordinary packet of crisps? How many of you seen that kind of thing? Things labelled as snacking, that's sort of seeped in the past couple of years. That worries me because it's targeted at children, because it's got all the, it's snacking things here and that, not like snacking apples, like snacking carbohydrates. Somebody said about relatives bringing in bags of chocolates and sweets for relatives that are diabetic. Yeah, it's an interesting one, and how you need, it's about education, how you need to do this. I agree with the point about hospitals and what their food provision is. So there's a few interesting points for us to think about. The average budget per patient in a hospital is about £1.12 for a day for the meals. So that's your 3 meals a day and your cakes and snacks. So it is quite difficult, and some of you may have seen the programmes again on BBC about how they want to change hospital food, and James Martin has been a pioneer in this area about demonstrating that good food could be actually produced for that budget, at £1.12 per patient per day. The other thing I'd like to raise is how many of you are aware about the sort of shops that they have in hospitals, that they allow, they contract space out for people like Greggs bakeries, Subway, McDonald's, to actually provide shops within the hospital environment. And again, you'll get relatives and you'll get patients wanting to do that. Some of you may know that. Yeah, somebody said about supersized portions. Great Ormond Street was the first hospital in the country, so for those who don't know, Great Ormond Street is Children's Hospital Specialist in London, to have a McDonald's in the hospital. Do you think that's a good idea or a not so good idea? The other thing with hospital meals is that you're asking people to potentially at one time, and some places still do this, is I'll ask you the day before what you want to eat the next day. I mean, it's difficult for me to do that, let alone somebody, you know, who's unwell thinking about the food for the next day, although we could say it gives structure to your day, that you're choosing your meals for the next day. Other areas actually do have hot food carted out and they say, this is what we've got on today, what do you want? You've got to think about portions and what, you know, what sort of portion sizes people want. You know, if they're not well, do they want to eat? I work in Cornwall, and they say in Cornwall, give a Cornishman a pasty and he'll be well. Well, it is interesting to see that the days that they do pasty on the menu is a day when most you know, this huge amount of pasties are ordered by the patients. So maybe that's improving their well-being and then their routine and their social norms, so you have to kind of think about that. And what about people who are on special diets and the hospital special diets meets them? Is it all right then to say to families, why don't you bring in food that might suit, they may prefer? Is there an issue with people bringing in their own food? It's the same as, is there an issue with relatives going down to Griggs and buying them a pasty and a pie at that point? Think about when Jamie Oliver did the thing in schools. The parents were pushing burgers through the railings because the children were getting healthy food and they were giving them burgers and chips and putting them through school railings. It's a bit of a national thing here, and I know I'm not saying anything that's new to you, but it's you know, there's been calls for the government to do something about the obesity in this country, and that's a real health promotion and an education thing. And you're right, in hospitals we don't always promote that. It's a symptom of the nation, and you know, we should think about the bigger picture and how that can be addressed. And you're going to be part and parcel of that. Your role as health promotion, giving advice to people about nutrition, is going to grow as we're living in times of needing to do something to do that. And there's no doubt about that. So yeah, it's important to, you know, promote good health to patients, and you may see you'll be required to do that as a matter of course with every single person who's doing an assessment and analysis. It's an interesting, but you've got to think about people's choices and preferences. When I worked in coronary care, they were, many years ago, they were advising, they advised people that high fat content cheese and salt in cheese wasn't a good thing for people with cardiac problems to have, so they deterred people from eating it. And then there's this little old boy, and all he ever ate was cheese, and didn't want to eat anything else. And it's about, well, actually perhaps reducing it rather than saying do not eat cheese. The same with people with, you know, giving them dietary advice and how to, you know, things like, and I've talked to patients who said, well, I was advised to eat pasta. Well, I've never had pasta in my life. I wouldn't know how to cook it. I wouldn't know what to do with it. So there's all that kind of thing that we don't always see straight away when we're talking about health promotion. And you've got to think about people's experiences. Anyway, before I get carried away, we will move on. Let's think about malnutrition. So it's about under and over nutrition. We've talked a lot about overnutrition, but you don't often hear the term malnourished used when you're talking about somebody with obesity. So that's interesting. What is more interesting is this. People are clinically malnourished. Yes, you've got the obese, but you've also got the people who aren't eating the eat well, the nutrients, the balanced diet. And when people are unwell, not having a balanced diet hinders regeneration, you know, recovery, and it's a big thing. We don't pay enough to it. So don't forget, people may have reduced ability to eat. We talked about poor fitting dentures and sore mouths earlier. There's a good example there. But people may have trouble with dexterity. I'm having trouble saying dexterity. You know, if people have got arthritis of the hands, for example, can they actually cut through meat? Something that's really annoyed me on many occasions is that people have been served up sandwiches in plastic packets and just left there, and they can't actually open the packets to eat them. It takes 10 seconds to open a packet of sandwiches and put it on somebody's plate, offer to cut it up for them if that's what they need, and place it where they can reach it. And these things have got neglected and gone amiss, and it's not right. So any chronic medical condition can affect intake and appetite and all those kind of things. Again, we talked earlier about mental capacity, but there's also, and I talked a bit about physical, about dexterity. Also, things like people at home, can they actually cook meals? Is it easier for them to bung something in the microwave than carry saucepans of hot water to boil potatoes or something like, or fry it, or cook, or put things in and out of the oven, for example? Is their illness affecting their ability to actually provide food for them, cook food for themselves, let alone shop for the food? And actually might be easier to bung something in the microwave. Mental capacity, again, people with dementia or learning disabilities may not remember that they've eaten and forget to eat, or only eat, biscuits or chocolate and things like that, because that seems very nice at the time to them. And there's a whole range of things that, again, when you're assessing, to consider, the cognizant and the capacity. Social issues, we're talking about finance here. And I've just talked about quick convenience food, and I don't know because I haven't had a McDonald's or anything recently, but I do see them advertised on telly. They're incredibly cheap. So if people have financial issues, is it cheaper to buy a big bargain bucket or something for the family than actually to cook food? And many people will say no, because you can eat cheaply and eat well, but it's that taking the time. And also this thing, you were talking about the social kind of thing. Domestic science and cookery at school, like, has gone out the window over years past, and maybe that sort of thing should be reintroduced. And also then moving away from all the social kind of things, we talk about reduced absorptive capacity. What I mean is the gut. If somebody's got problems with the gut and food's not being absorbed, nutrients aren't being absorbed, then there are going to be problems with malnutrition. Right. And some drugs interfere with the way nutrients are absorbed. So again, you need to look at what medications people are on and what things need to be addressed or adjusted there. So what happens with, malnutrition, muscle weakness, chest infections, problems with cardiac reserve, and reduced mobility. One thing important for us is those of us that when we work in hospitals, if people have got wound or pressure sores, then you've not got enough nutrients on board, you're going to get delayed wound healing, and you get increased risk of infection. The other thing is with malnutrition is the apathy, depression, and reduced concentration. And again, if you've got mental health problems and you're adding to it because the nutrition is not good, then you've got a sort of double-edged sword there. So, how do we assess? Oops, sorry, I thought there was a fourth one there. I do apologise. So, how do we define a nutritional status? How do we identify people who need nutritional support? And how do we evaluate that effectiveness? So, how can we judge? Every area you work in will have a nutritional assessment of some kind in use. Again, these will be evidence-based, and there are a wide range around. So initial status, so that you can implement and draw up dietary plans. There can be screening to identify people at risk and draw up a plan. And yes, screening and assessment are used interchangeably. Right, that's telling me to see what you guys are saying. So I'm going to have a little look at what points people have. Yeah, some of you have kind of come up with some of the things that I've sort of picked up and reiterated on. It's about health promotion to patients, health education for the young. Somebody's talked about domestic abuse being a cause of concern why people do not eat or overeat. It's true, but then you're similar also with other sort of mental health problems, again, change in diet or what people eat or overeating. can also be indicative of disturbance in people's well-being. Education and what's healthy, yeah, I think that reiterated what I was saying. And people addictions, yes. I'm not sure whether you mean drug addictions or you're talking about things like chocolate addictions or something similar. Maybe somebody would like to pick on that up. So yeah, we'll move on. Okay, so in 2006, the National Institute of Health and Clinical Excellence that you will be visiting and revisiting throughout your careers drew up some guidelines about how to identify when people should be screened. They identified that 13 billion was spent on illnesses and something needed to be done. So they said that people should be screened on admission to hospital when they first go into outpatients, or they've been admitted to a care home, or it's first time GP registration, or if there's a clinical concern. That sounds like fairly straightforward. They also said, which is not on the screen, is that all nurses and all nursing students should be trained in nutrition assessment, and this is part of your training. And you'll pick up some more in skills with you when you go into the skills ward, but also when you go into clinical practice as well. So one thing that's looked at the moment is body mass index. Most of you may well have come across this. Things there's a lot of signs stuck up in toilets around the place about body mass index, but also it's something you may have done for yourself. So we look at somebody's weight and height, and then we have a scoring system. Here we are, another scoring system. And depending on where you fit on that, depends on what you are. So you can formulate a plan from that. So perhaps you'd like to calculate your own BMI. If you haven't, I know we do this in the wards where you have a go at calculating your own body mass index. And here's a chart I was talking about that tells you the ranges. Again, you'll get a chance to use these. So what other screening tools do we have? There are 73 different tools available. That's a heck of a lot. But the one that is most commonly used is the malnutrition screening tool, MUST tool. And you will find this used in all your clinical environments, and we will do things in skills for this. And not that it's definitely going to happen, but I'm just hinting here that it's often a question that springs up in your written exam. So we do the BMI. Percentage of unplanned weight loss. So one of the questions we look at is, have you had any unplanned weight loss? This also is indicative of something like cancer as well, unplanned weight loss. So is there been any recent unplanned weight loss? How are they suffering from acute disease? Again, that affects the score. Add the scores together from questions 1, 2 and 3 to obtain an overall risk. And then you develop a care plan. This is something you may like to memorise. Hint, hint. Height and weight, BMI, unplanned weight loss, acute disease, add the scores together and calculate the risk. And then there are guidelines. So do have a look at MUST tools. We'll be using, here is one, you can look it up on the internet, and it tells you what you need to do. So the low risk is you recheck. Medium risk, you look at their dietary intake for 3 days, and then you look at increasing intake, looking at what things they need to do. If they're high, dietitian referral, nutrition support team, and look at what's going on there. So most commonly used, quite quick to do. These little flow charts are really good. We use them all the time in skills. You'll see them on the wards and in care homes and also in the community. So what can we do? Think about high protein energy drinks and meals. So you remember we talked about older people and unwell need more protein because what you don't want to do is for metabolism to switch so that the protein is being burnt up, and therefore the muscle is deconstructed to be using for energy, which is definitely what you don't want to do. You get muscle wasting in that way. I talked about opening the packet of sandwiches earlier, but people might actually need help with feeding. You know, have they got cutlery they can manipulate? Are things easy to cut up, stroke chew, wearing dentures, all those kind of things. Again, post-stroke, people might need help with actual feeding. You might actually have to feed somebody. Again, these are all sort of things that need to be taken into consideration. Making it look nutritious, making it look appetizing. You may be recording what they eat. So that's important to know. If somebody is having things recorded, because you have what they're given, and then before you take the plate away, you record what they're eating. Again, the appetite, the taste, temperature. You know, some people don't like cold porridge. I don't like porridge at all. But again, you know, who wants to eat cold potatoes? It's all that kind of stuff. Think about the portion size. Sometimes if people haven't got much appetite, just putting a small portion of something rather than something big that they feel, I can't possibly eat any of that because it just looks too big in front of me. You've got to think about all of these things. Again, snacks between meals, nutritional supplements, and I'll talk about protected meal times. So nutritional supplements, quite interesting. A lot of you will see them. You're going to get a chance to taste them and try them out when you go into the skills ward. But you can get these high protein, high supplement drinks that will have to be prescribed. And so people can have these to boost things when they're initially unwell. The danger of this is that it's very filling and it gives you all they want to do, but what happens is that if people drink all of that, then they don't want to eat food, and then when you want to start to wean them off the supplement drinks and get them onto normal food, we're into a bit of a problem area. So, you know, I've seen it prescribed 3 times a day, and I talked to this lady who was prescribed it 3 times a day. She was getting ready to go home and she said, oh, these are quite good, I quite like drinking them and they're making me feel better, but I can't eat as well. And I'm thinking, nobody's thought about what you're going to do when she goes home, because are you going to give her supplements to drink, or are you just going to let her just, you know, nobody's thought these things through. So supplements are good, but you've got to think about they're not a replacement for a nice balanced diet. Quite important. Protected meal times. Many clinical areas now in hospital environments will have protected meal times, and also in some care homes as well. And I went to work on a clinical area. They were doing some research into this, and it was a ward where there was stroke rehabilitation, and they asked the patients when about visitors, when would they prefer to have visitors? Can visit, you know, open visiting or restricted visiting? And what they said overwhelmingly is that they felt embarrassed to eat when they had visitors. 2 things. One, it's not polite to eat in front of somebody, so there's the cultural thing. The other thing is that a lot of people recovering from stroke have paralysis around the face, and so they may, you know, be dribbling or drooling or having difficulties chewing and swallowing food, and they felt embarrassed doing that in front of people, so they didn't eat if they had visitors. And so they surmised that needs to be protected. The other thing that happens in hospital environment is people get carted off for x-rays, doctors come and do their rounds, all sorts of things go on, and the research said actually people need protected time in which to eat, and you will find that. So it'll be interesting when you go out, again, into your placements to see if protected meal times are there. It's very widespread, and there's quite a bit of research behind that. Retray system, again, something that's brought in is going out again, is about, you know, could you take food back and bring it back out again? Or the other part of the retray system is identifying people who need nutritional assistance by giving them coloured trays to alert everybody to the fact that they need help with their feeding, which is an interesting concept. Again, a little bit of research behind that, so have a look at that. Yeah, there's Santa Claus. Okay, so sorry about that question. This is a standard thing that we use. So what I want you to do is think about what assessment tools you will come across being used when you go into clinical placement. Let's turn that off, and I'm going to just stop to see if there's anything anybody's raised or want to share with us. Where's my question box? Somebody's asked how much influence in any way we have over advising or questioning menus when on wards. Give it a try. You know, I worked on a cardiology ward, my first sister's post, and I was astonished that they were serving up heart on the menu. And okay, fine, heart. And when you lifted the tray up, there was just a heart on its own sat on the tray. And I thought, oh my God, how appetising is that? One, how appetising does that look? And two, interesting that they're giving it to people on a cardiac ward. So there's something for you. So we chatted to the patients about it and kind of said, actually, this, you know, some people might not want to eat this. Well, that was in the days when you didn't get a lot of choice about what you were eating. But I thought that was quite an interesting one. It's interesting about advising question menus on the ward. I think you need to kind of look at it. There's interesting things. They tend to, as I said, keep to a very tight budget. They tend to try things. They've tried having appetising descriptions of food, and that still doesn't help people with the choice they want. I mean, my personal belief, and as a practitioner, if people are really struggling to eat, you've got to think about alternative arrangements. And I worked in a clinical area where we had some people that had came in for overnight stays for specialist investigations, and we had somebody who was celiac, and this happened 2 or 3 times, and the hospital celiac menu was dire, if you could ever say that. So it's wheat intolerance in a big way, and it's like, would you like to arrange to have your own bread brought in, which might be nicer to eat than that? And there, you know, we did it, and the patients were extremely happy. If people are vegetarian, they usually now have vegetarian options, but sometimes you find that it's very limited. There is a danger, and I did pose this question to you earlier about people having their food brought in. There is this thing about storage, you know, bringing in cooked chicken and leaving it in fridges and bringing it in a few days. So you need to be very careful, and as students I wouldn't make those decisions and talk to patients and relatives about their own food. It's something you need to talk about with staff, because there is issues around food that needs to be reheated, or things like cold chicken sitting around with salmonella, and we have had, you know, incidents where people have been ill after eating food that's been brought in that was put in a fridge. So you've got to think there may be policies, but I feel there is leeway for everybody. If people are not eating because all they've got is a choice of hospital food and it's dire, then you need to think about food that they would prefer to have that would never be on a hospital menu, that would be suitable for them during that time. There is also, an interesting story about this happening. So this clinical area where I was sister, we had people in for who were not eating for 3 days to look at their glucose level and fluctuation over a 3-day period. And we always used to say to them, because when they started the trial, and they would have blood taken every 2 or 3 hours, it could be any time of the day, and what we always said to them when we admitted them is, would you like to arrange for something to be brought in for when you finish your starvation period, that would be appetising, please have it arranged, because it could be out of our sync of our meal times. And we always did this. So I came into work one morning and the night staff said to me, what did you tell Mr. Bloggs about eating food? I said, well, we always do that. I said he could, arrange to have something brought in. He said, yeah, he ended up ordering pizza for all the patients on the ward. Well, all 7 of them, because we had 7 overnight stays. He said, so we had a pizza delivery for all of them. I said, and they all fell about laughing. And I said, okay, fair enough. Okay, fine. So, yeah, interesting. Wasn't any problem at all. We all had some fun discussing that, but yeah, he thought, well, I'm having a takeaway being brought in by my wife. Does anybody else want any? Of course, then you've got to make sure that everybody else is eligible to eat what's being brought in. So you have to think about what the rules are, and you have to think about how are the rules applicable to everybody all the time, or are there times when it's important to have special food for people who can't or don't want to eat whatever you're offering them. And that's in a hospital environment. Care home environment, very much different. And again, if you're caring for people in their own homes, different again. So let's have a look at obesity. How about that one? 50% overweight. How much it costs? And this was in 2004, so the Department of Health, so we haven't had, well, there are figures, but not, this is the Department of Health or NHS England kind of thing. Complications of obesity, a lot are known. You would know a lot of these. High blood pressure is probably one of the biggest things that we're concerned about, as well as type 2 diabetes being the huge issue. Also risk of infertility. Heart disease, hypertension, heart disease. Again, the heart, you're asking the heart to do a hell of a lot to pump blood around fat bodies. Again, hypertension, heart disease, stroke. Depression, again, is another complication of obesity. Sleep apnea is quite worrying, and that's on the rise in this country. This is where the tissue between the chin and the chest, so your neck area, the obesity thickened around the neck and around the trachea, and causes sleep apnea, which means it obstructs your trachea while you're sleeping and you will wake up. And this is often thought to be the cause of many car crashes, or lorry drivers who may have sleep apnea, because if you get sleep apnea, you're not sleeping properly, and therefore you're tired all day and you don't sleep, and it gets in. People need help, and they need artificial breathing machines to improve their breathing and their oxygenation, because what happens is you get obstruction of the trachea, the oxygen levels fall, and you wake up. Very dangerous thing, and it's very much on the increase. So there's a lot of nasty things with obesity. And again, here's some trends, males and females. This takes up to 2010, which is nearly 17 years ago. And we know since 2010 things have increased even higher. But interesting, it's almost quite equal in males and females, and it is now. So our BMI again. And then there's this waist circumference distribution of body fats, indication of increased risk of morbidity. So this is the bigger the waist, the higher the risk. So this is all about this bad fat, they call it, that sits in the middle, your apple shapes, that sits around your organs and prevents your organs from functioning well. So again, there is a nice clinical guideline. Do look them up when you've worried or think about it, or return to this at a later date and think about things. So waist circumference, so everybody's going to now dash out and get a tape measure and see whether you fit into, are you at risk or not. So there for you to have a look on. And of course the other thing which we've touched on, health promotion to the young, but the rise in obesity in children is just taking off, and it's about that children's education that we talked about. So final discussion. Has anybody got anything to add or say to that? Yeah. Is it better for the government to spend a lot more money on health promotion, free cookery classes, exercise programs for people, than the amount they spent on the complications of obesity? Of course it is. It would be actually far less, because obesity and treating obesity is a huge burden on the NHS, and increasing, even to the point of beds not being big enough, to what you hear about in America, and it's coming over here, you know, people having to be cut out of their homes by the fire service because they can't get them out of their bedrooms and all this kind of thing. You're right, we need to attack it at that point. A lot more health promotion, cookery classes and exercise programs. And I think this is the big route in, and the government has to seriously think about it, and they have been seriously think about it, but there's a lot of things been going on in politics recently that have got in the way, and if you notice there's not a major amount of health and NHS related stuff going on at the moment. It will come soon, but you know, with the change in government, but interesting. It's very interesting. Everybody agrees that point that you're making. You know, where should we invest our money? Where should we invest our health promotion in our education? How can we make things different and change things? And there's a lot of public information out there, but it's actually getting it out to the harder to reach with people who ignore what's out there. And this is why you have a lot of programs on television, sort of health-related, eating-related programs at different times of day, targeted. I'm not somebody who watches CBBS and things like that, but I wonder whether, again, you know, should children's television be kind of more inclusive in health promotion? So now we've all stuffed ourselves, or not. Some of you may have, who didn't have anything to eat earlier, may be feeling like maybe they shouldn't eat anything now. But it's good for us to focus and think about this, because it is very important. And for you in your careers, it's going to be something that you're going to be very much part of the care and the change and the shift in things given. Because if you think the children today that are fat or obese, or the young adults, are the old people that you're going to be caring for in the future. And you know what that means in terms of things like manual handling, again, nutritional advice, and you know, the bigger killer diseases as diabetes and heart disease increase because of obesity. What are you going to be seeing in the future, and what are you going to be caring for? So good nutrition, screening assessment, what food, you know, what's good food groups, looking at how you can improve people's nutritional status, yeah, and then things like malnutrition and obesity, and actually not becoming part of that statistic about people, you know, starving in hospitals, people malnourished because hospital food either isn't appetising or enough, or that people aren't actually considering that somebody might need assistance to eat, and all those kind of things that go with it. So there's several issues there. Right, so that's the end of that. You've got some references and further reading for you to look up. Quite a little range of them for the time being. There's more stuff out there. Well, and again, as I said, I'm going to stop recording this now. So this will go up as a separate entity on the site. I'm going to leave Okay, folks, sorry about that. I've been raving on for ages, showing you lots of lovely pictures, and you haven't been hearing a single word I said, so I shall go back. I do apologise. It's only a couple of minutes. Oh, we're going to the end here. Sorry. How long have I been raving on for? Far too long. Let's start it again. I'm so sorry about that one. Right, okay. Let's talk about fluid balance. So, what is fluid balance? Difference between intake and output. Important to measure it at the same time each day. Often you'll see it midnight to midnight or 8 a.m. to 8 p.m. Oops, sorry about that. Clicked the wrong button. So what's important is to look at about the right amount of fluid in the right places, and illnesses and injuries can cause imbalance. Why is the measurement important? Essential for optimum health. Treatment and management related to fluid balance. Poor fluid balance can contribute to people becoming more ill, and it's worth looking at NICE and National Patient Safety Agency information. What does body fluid do? Transports nutrients and electrolytes, removes waste products, essential for chemical process, hydrolysis of food to aid ingestion, digestion, regulating body temperature, very key for that. It insulates the cells and like a shock absorber, and it's a lubrication for cells and organs. We've looked at this before, but you haven't heard me talking. Note, as you get older, your body retains less fluid, and things that can affect body fluid change, age, type, gender and health status. We'll look at that a little bit closer. What's in there? See, now I showed you a few minutes ago. I could have preempted by asking you this one. So electrolytes, gases, nutrients and enzymes and hormones, mostly in the blood then, circulated through the body to enable cell metabolism and body function. So without it, we ain't going to work. Osmoreceptors in hypothalamus trigger thirst when you drink, or you secrete antidiuretic hormones which affect urine production. So conserves fluid in the body, and this is why when you dehydrate you don't produce much urine. Okay, these things then in that case are all the sort of things that would indicate we need fluid balance. Anybody who's an intravenous infusion or subcutaneous infusion, fluid going into subcutaneous tissue, people that are being fed, people who have catheters, diarrhea and vomiting, again can cause dehydration because you lose large amounts of fluid that way. And here's a picture of a chest drain, so a wound drain, you want to measure the amount of liquid. And if people are on drugs that affect urine flow, like diuretics. Okay, these things are important to measure. What we take in is what we drink, food, and metabolism. Output our urine, and this thing called insensible loss. So the moisture, when we breathe in and out, the moisture that's lost through the lungs and skin, and then we add sweat to it, and then feces. Again, should be equal. Okay, where do we get our fluid from? If we drink, don't forget there's food. We talked about intravenous infusions. We talk about enteral feeding. Talked about that before, so through the PEG feed or parenteral, giving nutrients into a vein, and some drugs will come in liquid form. I talked earlier, none of you were listening because I had it all switched off, all about measurements in glass. How do we measure input? So you'll find several methods when you go into clinical practice, and this is what I want you to look at. Do the nurses give people at the beginning of the fluid balance chart a litre jug of fluid? Halfway through the day they'll exchange it for a fresh one. You measure what's been drunk out of it. You add your cups of tea. I'll be interested to see what is recorded as a cup of tea or coffee or anything like that. You may find 150 mils, the kind of thing they're talking about. Don't forget, if you give people tins of Coke or something like that, again, you measure everything. What gets missed often is that people might, like me, only have drunk half a cup of tea and it gets taken away and nobody's recorded it. So there is a lot of human error in monitoring fluid balance. So we're going to look at output. Look at all the things. Wound exudate. How can you measure what's seeping out of a wound? How do you measure vomit and diarrhea if someone's incontinent? Do you weigh the bed linen? Colostomy and ileostomies. These colostomies where the bowel is brought out onto the surface of the skin and there's a collection bag. Ileostomy where the bladder is removed and you have drainage into a little bag on the surface of the skin. Catheters. Traditionally, people are a bit more mobile, or you might give somebody a commode or a bedpan and they so often get forgotten to be measured, taken away by somebody else, not thinking that you're measuring that. This is why measuring individual drinks and measuring all of this stuff is traditionally badly done by nurses. Not enough attention is paid to it. And a better measure that you will see, especially if you work in cardiac areas or renal unit, is people will be weighed at the same time every day in the same clothes, like your pyjamas or a nightdress. That is a much more accurate measure of intake and output. Okay, so you saw this lovely little slide and you couldn't hear a single word I was talking about. I think it's important to think about low blood volume. You get thirsty if you lose 5%, 10% potential death. Not an awful lot. Not an awful lot at all. What can cause, we've talked about diarrhea and vomiting, poor absorption in the gastrointestinal tract, sweating and fever, hemorrhaging, losing blood, medications that affect the urine output, polyuria, you've got a disease where you're losing lots of urine, diabetic ketoacidosis, high urine outflow there. If you're not drinking enough, you're going to get low blood volume. If you haven't got the capacity or faculty to drink, again, we talked about the same things with nutrition. If you've got people with mental health problems or learning disabilities who forget whether they've drunk or not, forget to do that. And obviously, if somebody's lost conscious, they can't drink. The opposite one, hypovolemia. Again, people will be thirsty. Sorry, saying hypovolemia, not the opposite, sorry, hypovolemia, what causes it? You notice they may be thirsty, their mouths might be dry, they might have nausea, feeling dizzy and faint. For passing small amounts of urine, we'll talk about skin turgor in a minute. Their eyes look sunken, rapid breathing, rapid heart rate, low blood pressure, confusion and agitation, and reduced levels of consciousness. High blood volume. This is where there's an increase of fluid intake, but a decrease in fluid loss. These things are related to heart failure, renal failure, problems with liver cirrhosis, which causes problems in flow through the liver, and if somebody's been given rapidly infused intravenous fluids. What happens is the fluid will seep into interstitial tissue, resulting in fluid being retained and not being excreted. You could get problems with your breathing and coughing, fast heart beat, fast respiratory beat. The pulse feels very strong and bounding. The blood pressure may rise. People become confused and their level of consciousness is reduced. Similar symptoms to dehydration, hypovolemia, which is obviously tricky. So again, you've looked at this slide and I've chatted away, totally oblivious to the fact that none of you could hear me. Edema is, some of you may well have seen this, it's very common in elderly, lots to do with the fact that the heart doesn't work so well. Fluid gets retained and you'll get swollen leg here. The reason why this shape is like this around the ankle is because this person's been wearing a shoe which has stopped the fluid from seeping into that part of the tissue. As you can see, it looks a bit red and sore, which is worrying. If you gently press, you will leave a mark. It's called pitting edema because you pit when you push your finger in. And it will lead to mobility issues. And this is a long-term problem, and people will often be on diuretics tablets to reduce the fluid that's being retained in the body, to reduce the edema. If you elevate the leg, it will help because it aids venous return, but of course it affects people's mobility. Okay, poor hydration, increase in pressure ulcers, constipation. Because not much fluid is flowing through the kidney system and the bladder, you can get a raised risk of urinary tract infections. Puts more stress on the heart, so you're going to get problems with heart disease. Because people are busy, it increases the falls and it tips the diabetic control quite nicely out of control and makes it very difficult. So pause. I do apologise. I don't know how many times have I apologised? Far too many probably. Or not enough, I could say. Just going to have a look and see if anybody else is it. Right, okay. Since the audio has gone back on, hopefully that's all okay. No one's got anything else to say at the moment. Okay, let's have a look at dehydration in older people. Older people are at risk of dehydration. There is a high risk of illness, mortality, death and morbidity, associated diseases. Older people have diminished appetites and poor nutrition, and they may miss out on drinking. Again, it's about dexterity in their own homes. Is it a long way to go for them to get a drink? A lot of you, when you go into with community nurses, will often be ensuring people have got drinks through the day, etc. So what are we going to be doing when we're looking at fluid balance? We're looking to see their history in terms of what illnesses they have that might affect their ability to maintain fluid balance. You're looking for any clinical signs, the dry sunken eyes, the skin turgor, which we've got a picture of in a second, and also other things like the leg edema. And then there's your vital signs. That's what this means. This is your blood pressure and pulse, respiration, temperature. Also, you may be weighing people, as I talked about earlier. And then there's these things that I've just talked about. You know, can they drink unaided? Are there fluid restrictions imposed on them? How mobile are they in terms of getting drinks? Are there health problems that may affect their ability to drink? What medications are they on that might actually have that? And what's their capacity or mental status? Are they able to comprehend the importance of drinks? And if not, what systems then can be put in to support them? The other thing you might want to look at is the mucous membranes in the mouth. Are they moist, dry, coated, cracked? We talked about that with mouth care, but actually it's a good way of assessing hydration. What does the tongue look like? Is it shriveled, furrowed? The eyes, we talked about that. You might have distended veins in the neck, which indicates fluid overload. Capillary refill time. Reduced skin turgor. And what does their skin feel like? Is it cool? Is it swollen, like on the picture we looked at? What's their pulse like? We talked about strong or bounding or weak or throaty. Both of them are indicative of dehydration. Blood pressure, low or high. What is their urine? It should be 5 mils per kilogram in weight per hour. You might like to work out what yours is then on your weight. Is it dilute or concentrated? I've talked about weighing daily. And I've talked about fluid balance charts and recording. So, what causes problems? I've talked about access to drinks and poor mobility and dexterity. Again, preparing drinks, can they make cups of tea and things like that? Can they carry it? Are they recovering from surgery and illness? Are they weak in some ways? Have they had operations? Are they unwell? Are there difficulties in swallowing? As you get older, there's a reduced desire to drink. You know, is the drink that you've offered them getting warm when actually it'd be nice if it was quite cold? And you're not actually thinking about catering for their individual requirements. Are you actually providing people with drinks they like? I've just drunk apple tea. Not saying I wouldn't mind if I didn't drink it, but people have certain preferences. Are we catering to those needs when they're in care homes or in community hospitals or in their own home or in a hospital environment? So here we go. Here's something for you to try at home. Skin turgor. So, skin over a bony prominence, over the back of your hand, over your knuckle. Pinch gently, hold for a second and release. If it falls back into place straight away, you're well hydrated. If it doesn't fall back straight away and just hangs loosely, so it's inelastic, then you could be dehydrated. Quite a nice little quick test to do. So this diagram here is if it remains elevated after it's pulled up and released, it means your skin is turgid. So, having checked your own skin, if any of you need to immediately go and have a drink, please do. Otherwise, I shall carry on. Okay. So what's happening? We talked about nutrition hospitals. Let's talk about drinks. I've given you lots of things there. You know, are we giving people drinks? Are we being aware of their needs? Are we giving them what they want? The answer is no. The other issue is about several hours of nearby mouth. Is it necessary or unnecessary prior to surgery and after surgery? There may be problems with hydration levels. People may be confused and unwell and able to sit up and help themselves to drink. But there is a risk. So you should be, I'll put this onto Moodle, but you'll be able to have a look at this. She says, if it works like magic, it should do. Yes, we are. I'm just being impatient. So have a look at these guidelines. NHS Choices, very good site for information. Here's some of the symptoms of dehydration we've been talking about. And this is related here around heat, which is quite typical as it's very warm and what have you at the moment. What is severe dehydration? What sort of signs and symptoms there are? And how to look out for dehydration in babies. So have a little look at that. So where they are here. Let's have a little look. Talks about some of the signs and symptoms that I've already addressed, but it's something for you to follow up on. So those of you that worked in care, what have you seen? Have you seen people assisted with their drinks? Have you seen people left with drinks that they can't reach, like the packet of sandwiches I was talking about earlier? What do you think? Who helps people with drinks? Any thoughts? No one's going to particularly say anything at the moment. I'm going to take you to this to have a look at hydration assessment. If it works, it should work. This is some research, informational research about using oral mucosa to assess for dehydration. So what we're looking at here is a 3-week trial, how a nursing escalation tool, patient oral mucosa chart, can be used. So what they do is you look inside the mouth and see the status of the inside oral mucosa, and it identifies whether you're dehydrated or not, which is quite interesting. And so do have a look at this because it's an interesting thing that was being done and has been adopted. And here's another one for you. Then I'm going to have to log into this one. I shall pick that one up correctly. So again, it's about how to hydration toolkit, assessment toolkit. Hydration in patients in our care is highly important. It often gets neglected, and we can contribute to good hydration, or we can contribute to people becoming dehydrated. Age Concern have raised issues about patients' hydration and nutrition in hospital, and it's worth looking at what they've got to say. But a few years ago, this was national news. Some of you might stimulate some memories. So this chappie, 22-year-old, died of thirst. He dialed 999 from his hospital bed to beg a drink. So the coroner, this is a coroner's inquiry. He called the police. The nursing staff turned the police away and sedated him. He died after 5 days. Sorry, he died of thirst. He was let down by the incompetence of staff, poor communication and leadership, and a culture of assumption that other people will do what you haven't done, i.e. give somebody a drink. What the coroner said is he died at neglect. And there's a little bit. His pleas for help were ignored. If you're left without water and you're not drinking, because some people aren't able to drink, then we go back to our ice cube scenario that we talked about this morning. But news like this is very saddening. I know it was a few years back, it was 2012, but it is pretty shocking. And more recent Age Concern reports will highlight that they feel people are still starving and people have still got problems of thirst in hospital. So we need to talk to people themselves about why it's important to drink plenty and explain why. And as I said, when I worked in the renal ward, patients chose what sort of drinks they wanted at certain times of day. Some people who really, really like tea savoured it for the best time that they felt they'd enjoy it in the day. Ensure individual preferences are available. If they like to only drink stuff that isn't like on your normal tea trolley, then get it sorted. Help them, making sure it's in their reach, that they can, the cups, they've got dexterous cups. If people are confused or not cognizant and they need help to drink or encouragement to drink, then that's what you should be doing. Making sure that the drinking vessels that they have are important. We might need special OT for special supported drinking aids, special cups that are easy to hold and drink out of. Again, small drinks, little and often, is quite useful. Making sure it's fresh, not sitting around for hours a day, nice fresh ice, whatever, if you're giving water or squash or something like that. Think about oral hygiene, making sure that the mouth's not sore so it's not difficult to eat, and thinking about other ways and things to help. think I've laboured that point enough. Record an estimated volume if there's incontinence or vomit. Not as good as, but it's a way of doing it. Essential to record and report. Ensure that multidisciplinary teams are involved and reviewed. Here's our things not recorded will contribute and is our neglectful care. So it's a fundamental aspect of nursing care. It's important. Comprehensive assessment, and think about how you can assist people with drinking. It's something you guys can do very early on in clinical practice, but ensure that if you're offering and helping people with drinks, you need to be sure you know if it's being recorded and that it is recorded appropriately. Otherwise you'll be in the doghouse. And be careful. I'm really sorry again about the problems with there's lots for you to read. The fact that I have the mic turned off, I am so sorry about that. We've come to the end of our work together today. I hope I've given you some thoughts to think about. I'm hoping very much so that I've stimulated you to think about. A couple of things that you brought up. People are saying they've had experience of people left food and drinks rather than being helped because time isn't allocated and there's not much time. Well, time needs to be made, isn't it? These things can happen. Reports of people being dehydrated in hospital and reports of people not getting good nutrition in hospital. It's everybody's business, not the person who dishes out the teas or the lunches. It's everybody's business, and I'd like to challenge you to ensure that in the future we're not reading articles like this. And at this point, thank you very much for your participation or your sleeping while I was gaily talking away and none of you could hear me. And hopefully your placements will give you some things to think back on these things that we've talked about today, and refresh you. And also when you go into the ward and do some stuff around nutrition, hydration, elimination, hopefully it will come flooding back. Thank you all very much. I'm going to stop the recording now.